So the opiate withdrawal symptom management, I know we went through the scale, the COW scale, but what do we use here and with EPIC in terms of best practices for the management? So the opiate withdrawal symptom management order set is what we use. And again, it has a couple different aspects. It has patient care, medications, labs, and consults. Even though as nurses, we may not be activating these order sets, we may be using our SBAR communication or trying to help guide a provider maybe toward that order set to be able to use. So in the symptom management, again, the COWS is pre-checked for them. So hopefully they're ordering that and encouraging fluids. The multivitamins and clonidine is pre-checked for them as well, but there's other medications that they have access to as well for agitation, nausea, diarrhea, sleep, pain, all of these things. So agitation, again, there's probably a couple other things that we would recommend outside of this to have available, but these they give for essentially agitation and anxiety management. Your hydroxyzine, they give Zofran for the nausea, diarrhea. They have options for Imodium, sleep, again, Sonata melatonin are the options on there for pain. Tylenol and ibuprofen. Now, this is not for the medication-assisted treatment part of it yet. They do give morphine, hydromorphine as withdrawal management options here as well. And then labs, I know this is probably super tiny on your screen, but if they haven't been done already, we want to make sure that we're getting some basic labs on them. If they haven't done a urine drug screen, there's an option on here as well, looking at renal and hepatic functioning and magnesium, for a lot of patients, especially for the magnesium, if they're, having the vomiting and diarrhea, maybe want to check that. So give some basic suggestions, options there. It's going to want to encourage people to consult the case management and discharge planning because this will alert the case management social work around the need, if not for case management, then for substance use navigator or social work to see them regarding resources as well. So other common things, we hope you understand kind of why we focused initially on alcohol and opiates because it is not only very, very common, but again, the potentially two most deadly. So thinking through, what do I need to be concerned about first? Those are kind of the top two on the list. However, we all know that those are not the only things that people abuse. There's a whole lot, and if you're interested in kind of seeing different sort of treatment options and pathophys on any of these, the National Institute on Drug Abuse has lots and lots of information on all these kind of things. So the more common ones we see in the hospital besides alcohol and benzos and opiates, I think we've all probably seen some kind of stimulant or methamphetamine. PCP or the angel dust is kind of unfortunately coming back. We do see a lot of marijuana. We do see some hallucinogens, GHB, things like that. So we aren't in this presentation going to have enough time to go over all of them, but for interested parties, you can check out. There's a lot of great resources out there for them. But what do some of these things have in common with like the stimulant methamphetamines, amphetamines? Signs about use could be increased wakefulness. Again, some people are prescribed these even to help with wakefulness or to help with attention. You can see increase in physical activities, excessive talking, decrease in appetite. Sometimes it's the intended use of a prescription drug. Sometimes it's the unintended effect of a street drug. You'll see really rapid heart rate, sometimes irregular heartbeats. A lot of your folks that work on CHF type floors get a lot of our stimulant because it is so hard on the heart. But they can get hyperthermia. And I know we're going into summer season now, so this ends up being it's just a lot. It's a lot of work for the body. And people can come in really dehydrated, really elevated CKs, really challenging cardiac events when they've been abusing stimulants. Other things for intoxication could also include a feeling of euphoria or really intense pleasure. Essentially, when methamphetamine hits, it's this psychological equivalent of what your brain would get in terms of pleasure centers from 20 times your best day or 100 times your best day. It just floods these receptors of the pleasure centers of the brain, which again is part of the cycle of addiction, but also part of the challenge we see with withdrawal because it wears out these receptors. If it just dumped all the serotonin into your head and dopamine, and it's just hitting all the good stuff, and then abruptly discontinue, not only are those receptors like burnt out, but it's going to take so much more to even kind of get a feeling of pleasure again. Right, so they can burn those out. We can see increased aggression as well when they're intoxicated, increased interest in sex, hallucinations, delusions, paranoia. Again, very rapid pressured speech. They can get disorganized. Sometimes the teeth grinding as well. They really clench down their jaws and can grind away on their teeth. And we get a lot of dentition challenges and loss of teeth as well. For the withdrawal, again, early withdrawal is going to be about 24 hours after their last dose because they'll hit that peak. And then you see the crash, right? They sort of turn the corner. So very fatigued. About 24 hours after last withdrawal, they kind of come up, they crash, and then they wake up really hungry and carb crave a lot. That's where our magic turkey sandwiches can be helpful. Very irritable and kind of a mixed bag. They can experience anxiety or kind of creeping toward even severe depression symptoms. So that's the acute early withdrawal, which is like the first or second day that they're coming off of the stimulant. But the post-acute withdrawal can be up to 6 months. And again, that irritability, hostility can persist. They can get really severe mood swings, depression, really low energy, fatigue. Also like a brain fog. They've just been going. Some of that can be fatigue or lack of sleep, but other times it can be just overall fogginess, can't focus on anything, really, again, pretty much opposite of all of the intoxication states. So lack of interest in sex, increase in pain, because all those receptors that they were hitting on so hard are now burnt out, right? And some of them, again, if the brain is habituated to it, like all the other drugs, once it gets habituated, what it figures out is I'm getting all this sort of flood of serotonin, dopamine, all the things. So I can't take that much, so I'm going to start killing off some of those receptors. So what the brain actually does is it starts killing off some of the receptors in the brain so that when it has that much, floating around, it just sort of floats freeform because the receptors are dead. But those receptors don't really grow back. So as people go through the withdrawal, they have chronically lower ability to absorb some of these other chemicals in the brain because they burn out the receptors. So what are some of the common medications we use for management of agitation and or psychosis? We can use medications for a variety of things. Sometimes we're targeting a specific symptom, like an agitation or a psychosis, or some peripheral type of symptom, some kind of CNS component of it as well. But we also want to think about not just medications, because we tend to be very medication heavy sort of focused. We want to think about environmental modifications as well. And I don't mean just like safety modifications, although that's a good one. So if you have somebody coming in an active withdrawal, take a good look around that room. What needs to be in here, what could potentially be thrown at me, or what doesn't need to be in here. Do we need more light, less light? Do we need to have safety trays? Do we need to have medications available? Do we need to have, turkey sandwiches stocked on the unit? Kind of think about what you might want to have ahead of time before you think you need it or before the trays going flying, so that we are being proactive with it. If we know we need maybe multivitamins or hydration, are they able to drink something? I mean, sometimes we can ask them, what do you like better, juice or the soda, like trying to get them to work with us and partner with us on this detox. If they are having any kind of intense like nausea, vomiting, do we have IV access? We can try and be controlling for that so that we can be rehydrating them at the same time. Are we looking at promoting good sleep hygiene? And this one always comes up, and I know you're probably going to get questions at the end about how does sleep hygiene work with monitoring patients as well. because it's sort of this constant battle back and forth. Do I wake them up every 2 hours? Is this what it's telling me to do in order to perform these assessments? Or do I let them sleep? Because you also told me they need good sleep hygiene. And I would say, yeah, it's both. It's kind of like the stroke floor assessments. There's a reason why we're assessing at certain time intervals, especially early on in the assessment process, so that we can catch these symptoms up front. So if I'm like, but I want them to sleep, and I let them sleep, it's the, first into the 24-hour period that they're here, and they sleep all night for 12 hours and I don't do the assessments, or I just kind of poke my head and eyeball it. Again, a lot can change in those 24 hours. Remember those kind of, as those symptoms kind of collide, whether it's seizure type symptoms or whether it's, I didn't recognize early on they were sweating and sort of tachycardic, and maybe they, needed something in terms of medication or support earlier on, and now we're chasing it, right? So we want to make sure that we are monitoring. And again, these assessments don't take, hours and hours to do, but they are important to be done at certain time intervals. So we want to be proactive. We want to be thinking ahead of what we can be doing to help identify early on and control for those symptoms. So some of the more common things medication-wise that we use for agitation in particular are our antipsychotics. We have typical and atypical antipsychotics. Atypical are the newer ones. The side effect profiles better. The typical are a little bit older, and the sedation with the typical is a little bit higher. Sometimes we can sort of judge, well, maybe I needed an atypical antipsychotic for like mild to moderate agitation. Maybe I need a typical option for something that's a more severe, because if it's getting very, very severe agitation, you don't want to be waiting while you're calling the doctor and can I get some. You want to have it ordered ahead of time if possible. If you don't need it, great, but if you need it, it's helpful if it's there. If we're going to jump to a typical antipsychotic, oftentimes you'll see it given in conjunction with other medications like a Benadryl or a Cogentin, because it helps decrease the risk for a side effect, like the EPS or tardive dyskinesia, something like that. Sometimes you'll see them either one given in conjunction with like a benzodiazepine, Ativan, especially for withdrawal. The alcohol. In particular, sometimes we will give them alternating, right? I'll give the Librium, and then if I need to, if they're having a hallucination, something like that, I may give the Zyprexa, or I may give the Haldol, 2 hours later or an hour later, something. I mean, we don't want to create CNS depression. That's why we talk about, monitoring them for the sedation scales as well. But we do want to make sure that we have appropriate treatments available depending on what type of symptoms they're experiencing. So these IMs, they can be given anywhere in the hospital. IV medications, the more common ones we see used for agitation would probably be like Haldol or Thorazine. Haldol's a funny one though, because unlike other medications, it does come in all three forms. So it comes intramuscular, it comes IV, it comes orally, you can give it. But if you're giving it IV as opposed to the other two methods, they have to be on a telemonitor. So I know we're remote tele, so pretty much everywhere could have that, but you want to make sure if you have Haldol ordered, that they're on the telemonitor, you have that option, because otherwise it's not going to do you any good, right? But things like Ativan, those can be given, IV pretty much anywhere in the hospital. We're just checking for sedation. The more common oral medications that we see, so again, helps to know routes of access. You don't want to get something ordered that they're not going to take, or you don't have that route available. But it is pretty common to give oral meds. The typical antipsychotics are sort of our preferred, or I think I said atypical. If I said typical, I'm sorry. Atypical antipsychotics are the ones that we sort of prefer. Again, side effect profiles better. The common ones you'll see, the Geodon, Zyprexa, Abilify, which you probably remember from before, but also risperidone and Seroquel. You can see those given as well to help prevent delirium, to help treat delirium. Again, if it's a severe agitation, we can have typical antipsychotics, the Thorazine, Haldol, Prolixin are probably the most common ones. Other things that we see too, again, Benadryl, Ativan, Cogentin help control with side effects. Hydroxyzine, Buspar for anxiety, things like that. Sometimes Depakote, both as a seizure prevention measure, although that can be given IV as well. But we typically see it either for seizure or for mood stability. So if we have somebody who's maybe withdrawing and their mood's very, very labile, you could see something like that. And I want to put on their nicotine patches too, because oftentimes that is a big challenge for people that have been addicted, even if it's to things and smoking. because there's, if they're already going through one withdrawal, if we can prevent other types of withdrawal, it's helpful to address that nicotine as well. So the treatment, again, the different types of therapies, talk therapies, all of our T's are cognitive behavioral therapy. Motivational interviewing is kind of a key, as is harm reduction with our substance use disorders. Dialectical behavioral therapy is an option for some as well. Again, most of these, it may start, we may be planting seeds, for the people that are here in terms of assessing for their motivation, or what can we do to sort of, at least let you know what options are available. They may or may not fully enroll. I know sometimes that's the frustration. Patients are sometimes at different stages than we want them to be of change. So we can get ahead of them, but we want to make sure that we're educating, that we're utilizing some of these resources to meet them where they're at. There are self-help groups. Again, all of the anonymouses, there's ones for alcohol, narcotics, stimulants, codependency, there's lots of anonymouses. There's also smart recoveries for people that aren't necessarily into the anonymous type of format. These are more cognitive-based recovery groups instead of higher power. And then we have medication-assisted treatment. So that's, our different, opiate receptors, our Suboxones, things like that, or Vivitrol, but also assisted treatment can be making sure that we're treating their mood disorder, making sure that if they have underlying psychotic that maybe was exacerbated by a stimulant, that we treat that underlying psychotic disorder. For anybody that's, going out the door, still using opiates or prescribed opiates, we want to make sure that they have that Narcan prescription with them. So we have the whole medication-assisted treatment, the MapBridge program up and running. I know they've given information about that already, but we want to try and connect people to treatment if and when we can as well. A couple last things I would say about just being proactive. Hopefully everyone's aware of our behavioral response algorithm, behavioral management, so that we recognize if we are having withdrawals that don't seem to be well managed. We're already at kind of a level 2 in terms of our algorithm response, and that we should be escalating these things up, not just like, oh, well, it'll be next shift's problem. That we can use our behavioral management plans as well, not just waiting till they get out of control and we're calling, a code and can they leave, can they not leave? We can be preventative. We can identify if there are gaps early on. And if we're designing some of these behavioral management plans and it's day 1 or day 2, it doesn't mean we have to have all the answers. We can continue to add things as we go, or learn even in different admissions for a patient, what's going to work with them, what's not going to work with them. But the idea being, we have resources available. We want to make sure that we're utilizing them, and that we're using a team approach to manage these folks, that we're using our substance use disorder navigators, we're using social work case management, utilizing psych liaisons or psychiatry, spiritual care, security, our ALs, our nursing leaderships, because we don't want anybody to think like at the bedside, like either I don't know what I'm doing and I'm all alone and this is not going to end well. So just making sure that we remind ourselves that we have those resources available and that we're utilizing those resources. So I will ask at this point if there's any questions, although I may not be able to answer them if I'm not there with you, but if your CNSs know the answers, they will happily answer your questions. If there's something that they run into that they're not sure about, we'll work as a team and they can escalate it back up to me. And there is our references. All right, that's it for this.